Dr. Smruti Rekha.
Good afternoon, everyone, and thank you, organizers, for giving me such a great opportunity. Uh, to- Before proceeding, I should ask one question: that why do we even need another neurolytic tool in pain medicine? So, our goal in chronic pain medicine is not just to relieve the pain, but to preserve the function also. And we want pain relief that is predictable, reversible, and also durable. And what the available options that we have, the neurolytic tools like chemical neurolysis like alcohol, phenol, these all have comes with unpredictability along with systemic toxicity. If we look at the thermal radio frequencies like RFA, then it has a side effect of neuritis along with neuroma formation, and that is where cryoneurolysis fits in. That because cryoneurolysis that causes temporary axonal injury with preserved nerve architecture. So, before I discussing the techniques and mechanisms, another question I will ask that what is the evidence that cryoneurolysis actually works? So, these are few review of literature that has been published from Daradia House and Daradia Pain Clinic. This is the first center in India who has used cryoneurolysis, and this article has been published about the sacroiliac joint radio frequency, and this is the first published article in the world. So I'm going to describe briefly. It is a very important retrospective case control study, and that has been published in Indian Journal of Pain in the year 2023. And they have taken 83 patients, and they divided it into two groups. One group received intra-articular steroid injection in the sacroiliac joint, and another group received sacroiliac joint cryoneurolysis. They have used numeric rating scale, and when both the groups improved, but in every time frame, cryoneurolysis group has improved outcome, and they have measured it immediately after the procedure, 1 month, 3 months, and 6 months. So here one important findings, not only the pain score significantly improved, but proportion of patients also got benefited with cryoneurolysis, and they have achieved more than 50% pain relief with a duration of up to 1 year. Then here it proves that cryoneurolysis not only works, it consistently lasts longer than intra-articular steroid injection. So it is a better option than intra-articular steroid injection. Then this is another publication from our own work, and here this is in patient, this is a case report basically, and here what I would like to share this was a very interesting case report, and this is a case of mental neuralgia. Though it is a very rare and debilitating condition, the patient described pain with a very electric shock like pain and persistent and severe enough to interfere its daily life and sleep. Conservative management failed along with a lot of side effects like somnolence and nausea. So we in this situation, we used ultrasound guided cryoneurolysis because the rationale was very simple. Patient, this is a purely peripheral sensory nerve, and visualized under ultrasound and used for reversible neuroablative technique. So this is performed under ultrasound guidance, and patient had a significant pain relief. This is another articles that has been published by Narayan Panikar and Dr. Gautam Das in 2019. This is a very insightful article published in Indian Journal of Pain, but here the authors have compare all existing neurolytic technique like alcohol, then radio frequency, and where cryoneurolysis they found is different. And they describe cryoprobe technology, the physics of gas formation, along with the ice wall formation at the tip. And another important thing they have described, that is cryoneurolysis procedure has minimal procedural pain, immediate onset of action, and versatility in multiple pain conditions. Then this is another case report that has been published by Pathak Khan and Dr. Gautam Das. This is a very elegant case report, I must say, that cryoneurolysis is used in different and often frustrating problem is post-surgical scar neuralgia. And this is a 39-year-old female who has 4 years of pain along the scar after hysterectomy, and the authors find most important step, that is the diagnostic block, which came positive. After that they did cryoneurolysis along the scar tissue, and after that patient had a significant pain relief. Then this is another case report on the genital femoral neuralgia, and this is also by Dr. Khan, Dr. Kumar and Dr. Gautam Das. The authors here highlight cryoneurolysis produces reversible neural ablation, and the pain relief can last longer than 1 year up to 2 years. And here also, this is genitofemoral neuralgia that has been an iatrogenic neuropathy after inguinal surgery or hernia surgery. Here, the patient has undergone ultrasound-guided cryo-ablation of the genitofemoral nerve, and they have also marked and sustained pain relief has been shown. Then this is another case report where ultrasound guided cryoneurolysis of intercostal for intercostal neuralgia. As you know, intercostal neuralgia is very common. Almost 40 to 50% cases you can see after the thoracotomy surgery. Here the patient, it is very difficult to manage with the conservative treatment. In this case, the same thing happened. Patient was unable, many side effects of the drugs, and there was conservative management failed, and also medical management failed. And here, the patient experienced after undergoing the cryoneurolysis, patient has very significant pain relief. Then this is another case report on post-herpetic neuralgia. As we know, post-herpetic neuralgia is a very debilitating pain condition, and sometimes it is very difficult to manage with conservative management, and they have a very severe pain with persistent. This patient was having persistent sharp shooting pain along the intercostal nerve distribution, and the patient was not adequately controlled with medications and other conventional intervention also. He had taken local anesthetic steroid block, but it didn't work. Then after that, the patient had undergone cryoneurolysis of the intercostal nerve along the same distribution, and he had a significant pain relief. This is published. Here the authors Dr. Gautam Das, Dr. Rituparna, and Dr. Shushpa. Then now after review the literature, I will directly come to describe what cryoneurolysis actually is. So the goal here is to, as I have mentioned in my first slide, here goal is to reverse the reversible axonal injury while preserving the nerve architecture. And in cryoneurolysis, this machine is designed in such a way that it will produce second degree nerve injury. That means epineurium, endoneurium and perineurium, all the three structures are preserved with axonal injury. So our target here in cryoneurolysis is second degree burn, second degree injury. Unlike radiofrequency ablation where there is third degree burn, either epineurium or perineurium or epineurium especially, so damaged. So that is the reason neuroma formation in uveitis is common in radiofrequency ablation. So I have seen in many literatures and casual conversation also cryoneurolysis terms that has been used interchangeably. That's why I mentioned in this slide. Cryo-ablation, basically here what we understand, this is a broader term for destruction of the whole tissue, where actually the goal is to kill the tumors, especially it is used in oncology. But in cryoanalgesia, it is even a looser term which is used like in ice pack, cold therapy. But cryoneurolysis is the perfect term that is used in pain medicine, and it specifically referred to targeting the freezing of the nerve for the purpose of analgesia. And the target is the nerve, and the goal is the pain relief, and the intent is to preserve the neural architecture. Then coming to the cryophysics, how freezing occurs, how cryoneurolysis actually produces freezing of the nerve. So here what happens, the system uses a compressed gas, typically nitrous oxide or carbon dioxide, that is stored under high pressure inside a console. And the with the gas, when gas is released, you can see the probe, and it is not a, basically it is a probe, not a there is no lumen inside, or you can't inject anything, but the lumen is specifically designed for the gas. So here in this, when tip of the probe becomes extremely cold because of the Joule-Thomson effect. What is Joule-Thomson effect? There is a rapid when the gas is released, after the rapid expansion of gas at the probe tip, suddenly temperature drops down, and for carbon dioxide it drops down up to minus 79 degree, and nitrous oxide it is minus 88 degree. And that is more than sufficient to produce a controlled Wallerian degeneration of the nerve. And first, what happens, the size and shape of... Now, I will describe the characteristics of the lesion. Many thing matters in cryoneurolysis. Is not like unlike radiofrequency ablation, many factors that depends, lesion size depends on many factors. So first of all, the probe gauge and tip lesions. So here what happens, the probe, larger the probe size, like 18 gauge probe produces a bigger size lesion than 22 gauge. So you can't create the same lesion with the same gauge. So if you want to increase the size, then you have to increase the gauge of the probe. So and this size also comes in different size. There is a special probe which can create a large lesion up to 8 centimeter, has been used in sacroiliac joint cryoneurolysis. And the second thing is freeze-thaw cycle. So a single freeze create a smaller lesion, repeated freeze-thaw freeze cycle, they significantly increase the lesion size and the degree of axonal injury. Then third is the tissue vascularity, where you can see highly vascular tissue steal away the cold. That is called heat sink effect. That's why in the intercostal area or paraspinal area, lesion size is smaller than expected. These are the things. Because of these variables, the lesion width may vary from few millimeter to up to more than 1 centimeter, and the length varies from up to several centimeters. And that is the major advantage. We can tailor the size of the lesion and we can cover the whole area of the targeted nerve. Like in genicular nerve and also occipital nerve, these are the few examples. Then how cryoneurolysis reduces the pain. This is the molecular mechanism. Here what happens? There are 3 phases. There is first phase is your extracellular ice formation, where there is osmotic dehydration because water get pulled out, and because of dehydration cell shrinks. Once cell shrinks, as freezing continues, there will be intracellular ice formation and organelle damage, and as freezing continues, there will be microvascular injury leading to ischemia that again injures the action. And during the thawing phase, what happens? The cell water again rushes to the tissue and cell swelling and rupture occurs. So what happens to the nerve? There will be temporary disruption of the pain transmission, and there will be axon get disrupted and connective, but here most important is the connective tissue scaffolding will remain intact. So we can expect the regeneration of the nerve. So what are the advantage? Advantage, there is less procedural pain immediately after and during the procedure. Why? Because cold itself has a local anesthetic effect. And there is lower risk of neuroma formation and no chemical toxicity unlike alcohol or phenol. There is a controlled lesion geometry, and we can expect regeneration up to 2 years. And it is ideal when temporary but long-lasting pain relief is desired. Then these are the indications. All the indications I have mentioned in the review of literature. Another few indications are the like medial branch block and genicular cluneal nerve block, nerves we can use, and ilioinguinal and genitofemoral neuralgia. And motor nerve we have to select very carefully, because when you are inadvertently injure a motor nerve recovers very fast, but it takes temporary motor weakness will be there. So our target is most commonly peripheral sensory nerve and sensory dominant mixed nerve. So better we should avoid motor nerve, and rarely we can go for it. These are the contraindication. We should not perform this when there is an infection, when there is a bleeding disorder, when there is cryoglobulinemia, cold urticaria, Raynaud's phenomenon, and careful patient selection should be there. These are the risks we have to explain to the patient, like what to discuss with the patient. These are the things. Thank you very much.